lunch, time to recharge. There's a buffet lunch being served outside. We hope to see you here at 3 p.m. already seated for the next session. Please try to make your way back shortly before that so that we can have everybody seated and the first session of the afternoon starting on time. Thank you. Enjoy lunch. Back. I hope you had a very enjoyable lunch and got to stretch your legs and have some interesting conversations. We're going to continue into our next session dedicated to neuroimaging. I hope I don't butcher your name. Michel Grothe is the director of the Neuroimaging Unit at Fundación CIEN Reina Sofía Alzheimer Center in Madrid, and will moderate a session that invites us to dive into brain imaging technologies, showing how they can help detect different dementia-related brain alterations reflecting distinct pathologic components. Please enjoy.
Yeah, thank you for this introduction to the session. And little words to add, just that we have seen by now, like the very important, well, first of all, the great variety of neurodegenerative diseases or different pathologies that we're considering and we are recognizing these days. And it's not only all about Alzheimer's disease anymore, and also like not only the great variety, but also the significant impact these pathologies can have on cognitive functions and even on memory functions, mimicking, if they occur alone, mimicking even clinical phenotypes that mimic, that really look like an Alzheimer's disease, typical dementia. And of course, they can often co-occur. We have seen that a lot in the first session on neuropathology. They co-occur in the same individual and can modify the disease phenotype. And we have a big problem here from a clinical perspective that this pathology data is really interesting. It looks really nice. We're getting an idea of the problem, but we can't really do much about it because we can't really reliably detect all these different pathologies. Then validated molecular biomarkers really only for Alzheimer's disease available. Several developments in the pipeline. We'll hear about that in the next session. This session will be about neuroimaging. I don't want to raise too high expectations here, but we are not able to see these pathologic components with our existing imaging technology, except PET ligands for Alzheimer's disease. What we do see is the effect that these different pathologic components have on brain structure and function, and we can use that as indirect measures that can give us an idea of what may be the underlying pathology in a given patient in a clinical presentation. And with that, we'll start with our first speaker today, who's Dave Wolk. He's a professor of neurology and the director of the Penn Alzheimer's Disease Research Center at the University of Pennsylvania. Dave, I'm really happy you're here today. Dave is an neuroimaging expert in the field of AD and other dementias. He's been around for a long time in this field. I think I can remember studying his papers during my PhD thesis. So, and in recent years, his research has focused a lot on trying to understand the impact that different pathologic components, specifically LATE, and have on regional neurodegeneration patterns and on the medial temporal lobe, as we can see them in neuroimaging data. And most recently, Dave has also, within an international consortium in the context of this, he has led the development of clinical guidelines that may enable or that may help and guide the clinicians to detect, to raise awareness and detect late in the clinic. And if I say clinical, this also includes neuroimaging data. And so I'm sure Dave will tell us more about that now.
Great. Thank you very much, and thank you for the kind introduction. And very, very pleased to be here today. And I do think, actually, I suspect from all the speakers that what we're going to talk about really will dovetail well with the sort of brilliant sessions that we saw earlier in the day. It's a hard act to follow. I'm going to talk about some of the ways that we've started to try to tackle detecting some of these co-pathologies, and in particular in the context of Alzheimer's disease. These are disclosures. So I think, while there's mixed enthusiasm about this, I do think we're in a new era of AD therapeutics. We now are giving disease-modifying drugs to patients, and so in the States, these are FDA approved, and in our center, we've infused about 150 patients so far, and that number's, there's something like 200 on the wait list for us. And these drugs, I mean, I think if you take a step back, are pretty remarkable in that to think where we were 10 or 15 years ago, that now you can image amyloid in the brain, see the pathology in some levels that pathologists have talked about for years, and give an antibody and actually remove that amyloid from the brain. And so, with both of these new drugs, lecanemab and donanemab, there's really robust clearance of amyloid from the brain to the point where on amyloid PET scans, individuals are amyloid negative. However, there's more modest effects on cognition and function. So there's relatively modest slowing of disease progression, which to me, again, still is a remarkable achievement for where our field has been. And a great start, but only a start. And in general, these two drugs are pretty similar in slowing down the disease by about 30% on sort of standard clinical measures. And one thing just to, and the kind of link to things that we talked about earlier today, this is actually the spaghetti plots from the Trailblazer ALZ 2 study, which was the study of donanemab, and looking at cognitive outcomes in all of the patients in that study. And I think one thing this, that you can see is, one, there's a lot of variability in where people started on these scales, but there's also tremendous variability in a web of how people progress over time in the course of the study, treated or untreated. And so there's incredible variability and heterogeneity in the disease course, even at this very mild stage of disease. And I think you can see that in other data sets as well. This is work we did in the Alzheimer's Disease Neuroimaging Initiative data set, where if you look at a measure like PAC, which is thought to be this sensitive cognitive measure to preclinical Alzheimer's disease, and you look at spaghetti plots of individuals over a couple years in a preclinical group and an early prodromal group, people kind of go all over the place. There's practice effects, there's some people getting worse, some others not. And you could say, well, these are just noisy tests. But if we use a bit more objective measure, a measure of Brodmann's area 35 cortical thinning, which is where the transentorhinal cortex is that Brock talks about as the earlier stage, we clearly see, even in preclinical disease, evidence of decline, and in very early prodromal disease, even more evidence of decline. But even within that, on a structural measure, there's a lot of variability. And again, some of this is noise of the measure, but some of this is really related to differences in how people are progressing in the disease. And so Alzheimer's disease is an incredibly heterogeneous condition. And I think, we've talked about some of these things already. It's heterogeneous in its pattern of cognition, its speed, its age of onset. It's heterogeneous in the sort of background, the reserve and resilience that someone has when they get Alzheimer's disease. But as has been talked about today, one of the big modulators of heterogeneity of Alzheimer's disease are the presence of co-pathologies like vascular disease and other proteinopathies. And this is our experience, or at least on the your left. This is our Penn brain bank, and this doesn't include vascular disease. These are people who had autopsy-confirmed high Alzheimer's disease neuropathic change, or intermediate, actually. And if you look at this group, only about a third of them have pure plaques and tangles, and about one-third of them, more than one-third, have TDP-43 pathology, almost always in the form of late. And about a third have alpha-synuclein pathology, and sometimes those individuals overlap. And then if you look at the Rush data set, where here they're looking at a clinical diagnosis of probable Alzheimer's disease, and so the non-blue shaded areas reflect misdiagnosis, which is very common clinically without biomarkers. If you look at the rest of the patients, where they also include vascular disease and other degenerative conditions, the least common form of Alzheimer's disease is that little blue sliver here. So really atypical Alzheimer's disease is typical Alzheimer's disease when it comes to pathology. It's just not very common. And so kind of going back, why didn't we have a bigger effect with these anti-amyloid therapies? Why was it only a 36% slowing? And I think at least one answer or potential answer to that is these co-pathologies. And it's actually challenging to do this, to sort of break down in an individual person what percent or across a population, what percent of cognition is affected by Alzheimer's disease. This study used a kind of attributable risk of cognitive impairment or dementia. And basically, Alzheimer's plaques and tangles accounted for less than 50% of people's symptoms of dementia. And so Alzheimer's disease, isn't the only driver, and actually other pathologies accounted for a significant additional proportion. And then there was a sort of unexplained proportion as well. And so perhaps, if you give a drug that's only targeting amyloid, only targeting one of the main disease states that someone is in, it's possible that maybe there's a ceiling to how good any drug could work in this context. Maybe the best it could work is 50, 60% slowing, and maybe we're almost there, actually, with these drugs. Co-pathologies matter. I think this slide was shown earlier. So again, it's not just that co-pathologies are, bystanders. They at least are part of a milieu in which patients tend to have more aggressive disease. And so what you see here is, if you look at individuals who have, these are people without pathology or cognitively normal. If you look at patients with LATE, they have a much slower course than patients with Alzheimer's disease on a global measure of cognition, but the two together is associated with a more aggressive disease. And perhaps based on things that we talked about earlier today, it's linked to some interaction between these pathologies, but just there's also likely an additive effect from these pathologies as well. I almost pressed the button that I was told never press. I think it causes this whole place to evacuate. So how have we started to try to think about this in our patients? We are giving anti-amyloid drugs to people, and should we start to think about what their co-pathologies are, and can we better classify them? And certainly from a research perspective, can we start to learn, are people who have these co-pathologies more or less responders than others? And so we've kind of taken the approach to kind of think about the biomarkers that we have available, as Michel brought up earlier. And so, the old criteria, already old, 2018, there's a newer version of this, basically defined Alzheimer's disease based on its amyloid status, which we can measure quite well with amyloid PET and with spinal fluid, although I think also quite well now with plasma. And then we have really good measures of tau. In particular, tau PET is a great measure of tau load and tau distribution, and I'd argue we don't have great biofluid measures of that per se. And basically, if you have amyloid and tau, just like how a pathologist determines if you have intermediate or high Alzheimer's disease neuropathic change, if one has those two core pathologies, one has Alzheimer's disease. They're almost certainly going to have pathologic Alzheimer's disease. And then neurodegeneration gets this ignominious parentheses around the N because it's thought to be nonspecific. So we measure neurodegeneration, the downstream effects of this pathology, which include loss of synapse, loss of cells, through measuring brain structure and through measuring brain metabolism as at least the two most commonly used approaches, but they're nonspecific to Alzheimer's disease. Other conditions also create neurodegeneration. And so, it can help us with the staging of disease, but doesn't necessarily tell us what the underlying pathologies are. And so one thing, that we've thought a lot about is, well, how can we leverage the non-specificity of neurodegeneration to provide clues as to other pathologies? And when you think of what neurodegenerative measures are, particularly when they're measured cross-sectionally, they're going to be a combination of Alzheimer's disease-related changes, these other non-Alzheimer's disease-related proteinopathies, Vascular disease has been shown to have effects on gray matter structure. Some of it's just going to be age-related, and actually, I'll allude to or briefly mention, we have a brain age measure that we've been using that is designed to be orthogonal to what happens with Alzheimer's disease, and so even in the setting of Alzheimer's, you can kind of predict the biological brain age of someone. And then, and that's going to influence our neurodegenerative measures, and then inter-individual differences, right? So we all have different shapes and sizes, and we all have different size heads, cortices, and so that is a source of potential noise, but also a source of potential reserve or vulnerability in individuals. And so in the absence of non-Alzheimer's disease biomarkers, and right now we don't have one, although I think there are some on the horizon for TDP-43, and I think there's emerging markers also for alpha-synuclein, neurodegenerative measures may help support the presence of these alternative pathologies, and the patterns of that may provide hints to co-pathology. And I think with neurodegeneration being nonspecific, we shouldn't throw the baby out with the bathwater, as they say. I don't know who says that, but some people say that. And realize that while it's nonspecific, neurodegenerative measures are nonspecific, they do probabilistically associate with different underlying pathologies. So there are certain topographies to different pathologies. And so this was work by the UCL group where they had antemortem imaging in people who had pathology, and basically across different conditions, there are patterns you see. So 3R tauopathy, which is usually associated with Pick's disease, has a classic frontotemporal pattern. TDP type C tends to be very asymmetric and really involves temporal polar regions. Alzheimer's disease, particularly when it's late onset, tends to be more in the medial temporal lobes, and early onset, more cortical. And actually, structurally, DLB tends to not show much atrophy at all within the cortex, which maybe you'll hear a little bit about more in a few minutes. So, so when you think about how to look at co-pathologies, you have to think about where those co-pathologies are in the brain. And in particular, we focused a lot on LATE. I think earlier today, the criteria for LATE were mentioned. This was something that had been studied since really 2007, when TDP-43, a year after its discovery, was linked to hippocampal sclerosis, and was found to be quite common in the aging brain and also with Alzheimer's disease. And these criteria provided very sort of simplified staging scheme that were really designed to allow a pathologist, a clinical pathologist, to rate individuals well and quickly. However, there were earlier staging schemes, one by Keith Josephs and his group, and one by Julie Schneider and her group, that I think provide some clues as to what are the regions we should be looking at, and also what the phenotype might be. So, Keith Josephs points out entorhinal cortex as an early feature, frontoinsula, temporal pole, anterior temporal pole is affected, and orbital frontal cortex as well. And when LATE is looked at in terms of its imaging findings, it really does seem to match where there's TDP-43 in the brain. And so this is from the Rush cohort, and this is postmortem imaging. And basically, the more yellowish the color is, the more severe the atrophy is. And basically, you see this sort of anterior medial temporal atrophy as the most severe region, followed by orbital frontal cortex, but really fitting with where you see the pathology of the disease. And then this is an antemortem imaging study in which these cases had postmortem defined LATE. And again, you see this kind of gradient of anterior to posterior, more in the medial temporal lobe, a little bit less so laterally in the temporal pole. And so we've looked at these patterns to try to better define who likely has underlying LATE. So this is a study we did where we took antemortem imaging in individuals that either had Alzheimer's disease alone or Alzheimer's disease with TDP-43. And we used a very granular measure of medial temporal lobe structure that we've been working on for a number of years. And so this is the kind of medial temporal lobe unfolded. And what you generally see when you look at tau is it's much more strongly related with atrophy along the length of the hippocampus, whereas TDP-43 tends to be associated with more anterior regions, head of the hippocampus, and particularly anterior entorhinal cortex, and actually extends more anterior than this, and we've actually extended our pipeline to include those regions. Bottom line is, if you look at kind of a ratio of anterior to posterior, you actually get a pretty good discrimination of who has AD with TDP versus who doesn't. Even just hippocampal volume itself can be helpful. So this is another postmortem imaging study from the Rush group, where they looked at a variety of different combinations of pathology, and these are hippocampal volumes. And you'll notice that AD alone, relative to normals, or people without pathology, there's obviously hippocampal atrophy, but it's not super severe, whereas late tends to be associated with an even more severe atrophy. And if you think about it, if you take kind of the lower quartile of AD patients and you combine them with those with AD and late, just a sort of lower cutoff really enriches individuals who are likely to harbor late pathology as well. And actually, I think it does cause you to sort of take a step back and realize a lot of what we know about Alzheimer's disease and the kind of lower end of hippocampal atrophy and memory impairment is driven, I think, in part by these mixed pathologic cases more than pure AD. So one approach we've also started to take to try to think about how can we, in the face of Alzheimer's disease neurodegeneration, pick out the neurodegeneration that's due to other pathologies. We've taken kind of a simple idea, which is that in general, tau pathology is highly, highly linked to where there's neurodegeneration in the brain, where there's synaptic loss and cognitive dysfunction. And so this is from Bill Jagis's group as just a nice example of it. This is fluortaucipir PET, which is tau PET imaging at baseline, and this is longitudinal imaging. And really, the hotter your tau PET signal is, the more atrophy you have over time in almost precisely the exact same regions. And so, kind of simplistically, you could say, well, maybe tau is kind of an answer sheet to where neurodegeneration is occurring in the brain due to Alzheimer's disease. It might allow us to kind of parcelate out the effect of brain change due to Alzheimer's disease. And so we've tried to look at this. We look at this regionally in the brain. And so this is an example region in inferior temporal cortex. And as you can see, we get a nice linear relationship between tau uptake and cortical thickness. So you get greater thinning with more tau. But I think one thing that's notable is you have some individuals who have very little thinning for tau. And you have also individuals who have a lot of atrophy, much more than you'd expect for a given level of tau. And you might expect that these are more resilient and maybe these are more vulnerable. And you might expect the vulnerable people in particular to harbor co-pathologies. And so we started to look at this actually on a case-by-case level and sort of thresholded being 1.5 standard deviations below the mean in terms of these vulnerable defined areas. And we started seeing cases that seemed to kind of cluster together. So we started seeing a lot of these sort of temporal polar cases. And then we also started to see a lot of these sort of diffuse cases. And so we ran a machine learning kind of clustering algorithm to look at residual maps of the brain after you regressed out tau, or if you will, you could say after you've regressed out the effects of Alzheimer's disease. And we see a bunch of patterns. We see a canonical group who have kind of the Goldilocks right amount of tau for atrophy, but we also see a group that has more temporal polar atrophy, and then we see a group that has more diffuse atrophy than expected for tau. And then we see some of these resilient groups that might reflect people who are more resilient to a given level of pathology. And there are some different patterns in those as well. And I think importantly, clinically, is that these vulnerable groups actually have a much faster rate of decline than the canonical group in black, particularly the limbic group, kind of like late plus AD. And actually, if anything, the resilient groups tend to have very little or no change over time in those individuals. So maybe important information before you're going to start a therapy in someone. And actually, you know, if we're kind of removing the effect of Alzheimer's disease, we'd expect to see similar patterns in amnestic patients who, you know, from the Alzheimer's Disease Neuroimaging Initiative, who don't have amyloid, that we should see the other pathologies that these residuals are made up of. And in fact, we did see the exact same patterns when we looked at amyloid negative individuals and sorted them by cortical thinning. And I do want to point out that our limbic vulnerable group looks a lot like that postmortem imaging study I showed earlier in terms of the pattern of where there's the most atrophy, particularly kind of anterior medial temporal into temporal pole and some orbital frontal. And we could then link these different vulnerable groups to other kinds of markers of co-pathologies. One I actually added in because we had talked about brain age earlier. This is a brain age gap, and generally we saw in these more vulnerable groups, whether we're looking at amyloid positives or amyloid negatives, that the more vulnerable had greater brain age and the more resilient had younger brains for a given level of pathology. And then we also in particular found that that diffuse group tended to have higher levels of white matter hyperintensities and vascular risk factors than the other groups. And so perhaps that group's extra atrophy is driven by that pathology. We also did this clustering using antemortem imaging and postmortem measures of tau and actually replicated the clusters and importantly found that this limbic vulnerable group also had elevated levels of TDP in the brain as well. And so it does seem to kind of map onto TDP co-pathology. We've looked at this with postmortem imaging, which is a big part of the work we're doing, and I won't have time to talk about too much, but we're doing 9.4 Tesla MRI on hemispheres in our patients and can, in a more granular way, measure the medial temporal lobe. And so we kind of wanted to look at this residual effect, and what we could do was take our measures of structure and relate them to tau in people who just had amyloid and tau. So kind of what's the right normative relationship of atrophy with tau? And then put in, we can look at our TDP-43, our late cases plus AD, and they all fall, or most of them fall well below that regression line. And in fact, they fall below it in a pattern that's more anterior. It includes CA1, entorhinal cortex, somewhat subiculum, and then also less so in more posterior and lateral regions. So kind of in keeping with where there's TDP. So I think this is a useful marker. One or two other points. We've looked at this with FDG PET and have seen a similar pattern. FDG PET may be more sensitive, though, to things like Lewy body disease. And again, I'll just point out that the vulnerable groups here relative to canonical had faster rates of decline. But we were wondering whether this cortical susceptible group might have alpha-synuclein pathology. And actually, markers of things like hallucinations and this imaging feature called cingulate island sign tended to be higher in this diffuse vulnerable group. And then actually, now they're, in the ADNI data set at least, they have this seeding alpha-synuclein amplification assay for measuring alpha-synuclein in the brain. And one of the things, if we kind of do the reverse, take amyloid positive people with alpha-synuclein versus without, and then look at their metabolism to tau, we see that that group had greater hypometabolism relative to tau compared to the group without alpha-synuclein, kind of in keeping with this mismatch approach. So in just a final couple minutes, I just want to give a plug for our proposed clinical criteria for LATE, because I think we now have learned enough about the characteristics of this condition to at least diagnose it probabilistically in practice, and I think it's important for us to start to do it in research studies so we can better follow those patients and learn more about them as opposed to just waiting for postmortem studies, including also for testing biomarkers. So this was a committee that Michel was on of 36 experts within the field that had a workshop and then developed diagnostic criteria. Because we don't have a TDP-43 specific biomarker, diagnosis is best probabilistic. And we really defined LATE in two different categories. One is when LATE is the primary driver of symptoms. And in those cases, we can apply a possible or probable LATE. And then also thinking about mixed cases, at best, I think we can get to the point of being kind of possible LATE. And I should say these kinds of designations have been used in neurology for years in neurodegenerative conditions and used to be what we did with Alzheimer's disease. And so in order to have LATE as the primary driver, we expect a kind of core clinical syndrome of amnesia, other domains largely impaired, maybe a little bit of semantic memory impairment and a very slow course. With AD, it's harder because these patients will look like AD patients in that they'll have an amnestic multi-domain syndrome, but they likely have more memory loss than suspected or generally relative to other domains, and they generally have a more rapid course. And then one can apply an algorithm to this, where if you have the core clinical features of LATE and you have significant hippocampal atrophy, you can then use, if you have them, AD biomarkers, but if you don't, the best you can really say is possible LATE. If you have amyloid and you're negative, I think these cases, we're pretty sure most of them are LATE, because there's not a lot of other things that produce this much atrophy in the medial temporal lobe in amyloid negative older individuals, although there are some exceptions. If you're amyloid positive, though, and you're tau negative based on tau PET, there I think we are also in pretty good ground to say you likely have LATE, in part because tau is very linked to medial temporal atrophy, and if you're negative for tau, it's very unlikely that you have a lot of atrophy from tau. Obviously, if it's positive, you have mixed, or you have Alzheimer's disease, and you may also have, could be mixed with LATE, and then that takes you down this other path, which really, to a large extent, requires supportive imaging features that suggest more atrophy or more hypometabolism in LATE-like regions than expected for where you are in the disease. And that, again, I think the best we can get there is possible LATE. So just to conclude, Alzheimer's disease is heterogeneous, and co-pathologies are a major source of that heterogeneity, and better defining more vulnerable or resilient individuals, I think we're in a therapeutic age right now, and we need to start to designate those patients and start to study, what are the signs that suggest someone's going to do better or worse with these medicines. And so I just want to thank my collaborators. Many people have worked on some of the data I've talked about, and actually the co-authors for the clinical criteria. Thanks for your attention.
Thank you, Dave, for this great presentation. So we'll have questions at the end of this session because we have a lot of overlapping information here, and so we can have a common discussion all together. So we'll jump straight to our next speaker, who's Jesús Silva. He's a postdoctoral researcher in our neuroimaging unit at the CIEN Foundation. And he will, I think, pretty much complement Dave's presentation by providing more data on FDG PET as another very valuable imaging modality in addition to structural MRI. Jesús.
Thank you for the kind introduction, Michel, and also for the organization for counting on me for this task, and also for the bravery of having a session about neurodegeneration. That would be a very boring topic some years ago. And now we are again in the round, and I will complement very well, I think, what Dave already showed you, but focusing more in hypometabolism and a different measurement of degeneration that is not exactly equivalent to atrophy, as we will see during the presentation. So, just to summarize what we have already seen multiple times during the day-to-day. So up to 55 million people worldwide suffer from dementia, and according to the clinical diagnosis, so what clinicians say, almost 70 to 80% of these have Alzheimer's disease. However, this clinical diagnosis is not the gold standard for diagnosis. It is neuropathology, and neuropathologists said that actually around 30% of the patients with a clinical diagnosis of AD that get to the autopsy will not fulfill the neuropathological criteria. So we may assume that some of these patients with clinical AD will have other pathologies that may be mimicking AD or can be confounded with AD. And to get everything more complicated, as we already seen several times during the morning, of the patients that actually have a diagnosis of AD, most of them will have some form of co-pathology. So the reality is that most of our patients will be in this small square here. And to see how a cohort of clinically diagnosed patients actually look like, I bring it two examples for you. So this is a slightly different to what we see during the morning that was more diverse cohorts. All of these patients, they have the same diagnosis. They are amnestic MCR or clinical AD patients, and it's more similar to what we already saw in David's presentation. And we can see here that only around 30 to 35% of them actually have pure AD. And the other pathologies contributing to these cohorts, as already was discussed by David, are, on the one hand, LATE, of course, and on the other, Lewy body pathology, whether they are observed as a co-pathology to AD or they are observed isolated in 5 or 10% of the cases, approximately, respectively. And I will not go too deep in LATE because it has been discussed many times and we just heard to a world-leading expert in the topic. Just to remind you some relevant characteristics that would be relevant later in this presentation, I would remind you that LATE is associated with advanced age and generally a very slow cognitive decline compared to Alzheimer's disease. And that is very amnestic predominant, so other functions like executive function will be very spared compared to AD. And in terms of genetics, we expect a lower frequency of the APOE4 allele and a higher frequency of the, sorry, I almost touched the untouchable button also. And we'll expect to see an enrichment of TMEN106B, which is a gene that is associated with other TDP43 pathologies, and that was very deeply discussed in the morning. And I found Lewy body pathology a bit interesting because, of course, we expect that LATE would mimic AD and will present with an amnestic phenotype, but we may usually expect that Lewy body pathology will be associated with much different clinical features like Parkinsonism, sleep disorders, hallucinations, and generally a more executive impairment in the clinic. And of course, this is true. This is what we may expect from Lewy body dementia and Parkinson's disease dementia also. But in early stages of the disease, and for example, we can see this very nice paper that examines a cohort of patients with dementia with Lewy bodies, and we can see that for most of them, their first reported symptom by the clinician is memory loss. So it's likely that these patients are exhibiting a more amnestic phenotype before they develop a full Lewy body phenotype. And following the reasoning that David already stated in his presentation, if we look to the biomarkers that we have available, how can we detect these co-pathologies? So in the first place, we have biomarkers of amyloid and tau, and this will only tell us if our patient is in this circle with AD neuropathological change or not, if the biomarker works really good. And then later, more recently, we started to have some biomarkers that will give us information of some complementary pathologies or co-pathologies. For example, we have alpha-synuclein amplification assays, and with this, we can receive some information of some patients here. So some of them will be positive for this Lewy body biomarker and will not have AD, and some of them with mixed pathology will have both. However, as already was very nicely exhibited, despite being non-specific, which is a weakness, neurodegeneration biomarkers can potentially give us information about the whole spectrum of causes behind cognitive impairment. And this is done through patterns. And here I show you some examples of patterns of hypometabolism that we usually see in FDG PET for different diseases. So for AD, we see this very well-known temporoparietal pattern that also affects the posterior cingulate and the precuneus. And just below this, we have the pattern for DLB, and this is characterized, or the main difference between these patterns is the affectation of the occipital lobe and a relatively spared medial temporal lobe in dementia with Lewy bodies. And we also have here for reference a pattern for frontotemporal dementia. We can see a very frontal and temporal affectation, which again, as already mentioned by Dave, follows very well the neuropathology of the disease. And I've discussed up to date, two questions may arise. The first one is, okay, so if a patient has the two diseases, so if he has AD and DLB, he will show a mixed pattern, so we can expect that he will show a characteristics of these two differentiated patterns of the two diseases. This would be a valid question. And another question would be, if a patient that has an amnestic phenotype and doesn't exhibit any DLB characteristics would still exhibit this pattern that we have derived from patients that actually have DLB, so maybe it's more closely associated with DLB clinical presentation rather than the actual neuropathology. And of course, to answer to these questions, we have to rely on neuropathological data. And to do this, we started examining data from the ADNI cohort. This is a very common research cohort, and follows a large population of patients. Some of them have died and have went to neuropathology, and in the data I will present, roughly between 60 and 75 of these patients will be present because the study has been advancing as we were doing our research. And they have been staged for AD, Lewy body pathology, and also TDP-43. And for each of the pathologies, we have staged our neuropathological cases in pure AD, AD plus late or AD plus Lewy body pathology, and isolated late pathology and pure Lewy body pathology. And the first finding here would be that the patients that have both pathologies, so they have mixed AD and TDP-43 or mixed AD and Lewy bodies, they don't exhibit a different spatial distribution of hypometabolism that would be able to help us distinguish them in the clinic. So we can see that the AD patients show this temporoparietal pattern that we saw earlier, and the pattern in the late plus AD patients is extremely similar, and the same, more interestingly, I think, in the patients with AD and Lewy body pathology, and we can see that we stated that the occipital lobe was the main difference, and we can see that it's perfectly preserved here. Just for expanse with some discussion that we had in the morning, we also compared amygdala Lewy bodies that are very specific and well known to be co-pathological to AD, and compared them to limbic and neocortical Lewy bodies, and we didn't observe any notable differences in the neurodegeneration pattern between both categories. So this already answers to the first question that we made, that if we would be able to use FDG PET to detect co-pathology, and the answer would be that no, because it doesn't have an effect in the neurodegeneration pattern, at least in these very well characterized amnestic phenotypes. However, we also observed that in 14% of the patients of our cohort with isolated late pathology, we saw a very different neurodegeneration pattern in FDG PET that was very primarily observed in the medial temporal lobe and completely spared the parietal and lateral temporal. And very similar for Lewy bodies, we observed that in 12% of the patients with pure Lewy body pathology, the pattern was clearly different from AD, and we can see here the occipital affectation in the pure Lewy body cases and a completely spared medial temporal lobe. So to the second question, will LATE-NC or amnestic Lewy body pathology associate with distinct FDG PET patterns, even in these very amnestic populations? We would expect that this is the case. And most interestingly, in the Lewy body study, we observed some additional variables in the autopsy, and one of them was the substantia nigra neuronal loss. And we might expect this to be very specific of Lewy body pathology. It's a well-known feature in Parkinson's disease, for example. And we can see very low neuronal loss in the substantia nigra in pure AD cases, and very high in the pure Lewy body cases. And if we focus in the co-pathological group, we can see that it's somewhere in the middle, nothing very significant, but you can see that the value is sort of in the middle. And indeed, this middle value was driven by a small subset of mixed cases that actually showed increased substantia nigra neurodegeneration. And in this small subset of cases, we indeed were able to see this more DLB-like pattern. So we believe that this means that despite ADs being the dominant factor driving neurodegeneration, in some rare cases, it may be the other co-pathology, and in these cases, maybe we can identify it using FTG. And of course, after all this autopsy work, the question that may arise is, is anything meaningful in the clinic? So if we see these patterns in amnestic patients in the clinic, do they mean something? And to answer these questions, we continued our studies in the in vivo side of the ADNI cohort. And our cohort comprised around 1,200 patients with a diagnosis of amnestic MCI or AD dementia from ADNI. We first analyzed 242 patients with a confirmed diagnosis of AD dementia, and we wanted to classify these patients into AD-like or late-like according to their hypometabolism pattern. So we developed a differential spatial correlation algorithm that if the pattern in the patient was very similar to the late pattern that we derived from autopsy, but very different to the AD pattern, we'll classify the patient as AD-like. If the opposite situation happens, so it's very similar to the AD-like pattern, but very different from the like, it will be classified as AD-like. And of course, we also observed some other sets of cases like this mixed case, but we excluded this from our analysis because we didn't observe an effect of mixed pathology in the autopsy, so we don't know how to interpret this. And also, it is possible that some patients, they have a hypometabolism pattern that is completely different from both pathologies. So following this algorithm, we classified 25 patients that was around 10% of our cohort as late-like, and 77 are as AD-like, and we can see a very nice reproduction of the autopsy patterns just as a confirmatory result that our classification actually works. And if we compare these groups to see if we can see any clinical differences between them, we can see that late-like patients were significantly older. They were very slow progressors. And we also calculated this variable, that is the Z-score difference between memory and executive scores. So a negative value in this scale would mean that the patient is more amnestic, and a positive value that is it's a more dysexecutive cognitive profile. And we can see that late-like patients, they are more amnestic than AD-like. In AD biomarkers, we observed that late-like patients have significantly less abnormal AD biomarker levels. And in genetics, we can see that they are lower frequently carriers of APOE4. In fact, we only observed a small subset of plus cases in the AD-like group. And they are more frequently carriers of the TT risk allele in the TMEM106B. And they are completely absent of CC, so of protective variants. Most recently, we also extended this work to amnestic MCI. So this is an interesting approach because we know that late is a very slow in progressive disease. So we expect that MCI populations may be enriched for these late patients. And in a large cohort of AMCA patients with 909 subjects, we identified 105 possible late-like patients. And again, similar to what we see in AD demented patients, we can see a slower progression in these patients. They are older. They have less abnormal AD biomarkers. And we also evaluated tau PET, and we can see differences in SUVR in BRAC areas, but some cases have elevated tau. And we also performed a visual assessment of this tau PET using the visual read method in the FDA label of flow tau severe. And we observed that around 40% are tau positive, so we still need to refine a bit our classification to actually get to a better result in this area, with at least with the MCI patients. So as an intermediate summary, and I see I'm going very bad in time, we can say that the late characterized by a specific temporal limbic pattern in hypometabolism that differed clearly from typical temporal parietal hypometabolism in AD. And that patients exhibiting this LATE-like FDG PET pattern showed lower AD biomarker levels and clinical and genetic features consistent with LATE. Going to our DLB study, so we did a very similar classification, and we observed that from 10 to 20% of our clinical cohort, including both the MCI and AD patients from previous studies, showed a pattern of hypometabolism that was consistent with DLB. And between this DLB-like and AD-like patients, we didn't observe any difference in mini-mental, but we observed a significantly more executive cognitive profile using this theta score, the difference variable that we were referring earlier, in the Lewy Body-like groups compared to the AD-like. And this difference was driven primarily by a worse memory performance in the AD-like in NCI and a worse executive performance in demented patients that were DLB-like in the FDG PET. Regarding amyloid and tau biomarkers, we used here imaging, and we can see that we observed a higher amyloid load in the DLB-like, in the AD-like patients, and also a lower tau load in the, lower amyloid and tau load in the Lewy Body-like. And very interestingly, we observed a relatively higher tau uptake in the occipital lobe in the LB-like that is a nice reproduction of a previous result from both dementia with Lewy bodies and also posterior cortical atrophy. And regarding cognition, I will go to our most interesting result. So we observed very similar progression, a global progression, but a slightly worse memory progression in the AD-like group. However, very interestingly, we observed that patients showing a Lewy Body-like hypometabolism pattern were significantly higher, at significantly higher risk of developing hallucinations over follow-up. So in some sense, FDG is predicting to some sort the development of a more DLB-like phenotype in these patients. And just to conclude, as David already mentioned, we now have some fluid biomarkers to measure alpha-synuclein in CSF. And a very recent paper has shown that these are effective to some extent to see co-pathology in AD. And using these biomarkers, we segmented subjects in AD+ and LB+, AD minus LB+, and AD plus LB+, and minus, very similar to what David already showed. Just to highlight that in the hypometabolism pattern, we can see here in AD+ versus patients with co-pathology, a very nice replication of what we already saw in the neuropathological data. So the exact same neurodegeneration pattern with the very well-preserved occipital lobe in the mixed patterns compared to the patients with only Lewy body pathology, where we see this clear occipital affectation and spared medial temporal lobe. Just to complement the result that David already showed us with LATE, we can see that the blue line corresponding to the mixed case, they are faster progressors than the cases only with AD. However, and just to, this is to conclude, we can see that if we analyze again hallucinations, so this value that we use it as a proxy of a more DLB-like clinical phenotype, we didn't see any differences between groups when correcting for hypometabolism, age, and global cognition. And in fact, just having some sort of hypometabolism, so some sort of neurodegeneration, was by far the stronger predictor of developing hallucinations irrespective of the pathological group. And most interestingly, when we take this into account and filter here our patients with hypometabolism, we can replicate the difference that we saw earlier, and we can see that patients showing a Lewy body-like hypometabolism will have a higher risk of developing hallucinations irrespective of the pathological group. So just to summarize, similar to what we observed in LATE, a sizable group of amnestic patients will present with posterior occipital hypometabolism suggestive of Lewy body pathology. And this will associate with lower AD biomarkers, a distinctive dysexecutive cognitive profile, and a higher risk of developing hallucinations over time. So even without any a priori suspicion of DLB, these patients should be followed closely in the clinic. And even after testing for alpha-synuclein using fluid biomarkers, the FDG PET was still informative of the risk of developing more DLB-like features. And that would be all, just to thank our amazing group in Fundación CIEN and also our collaborators in the Gothenburg University that contributed to this work. Thank you.
Okay, thank you, Jesús. So we come to our next and final speaker, Laura Jonkman. She's an assistant professor of anatomy and neurosciences at the Amsterdam University Medical Center. And one can say that she's a perfect addition to this session here to wrap it all up, because Laura's group is basically spearheading in Europe the field of combining neuropathology with post-mortem MRI to get a really closely matched correspondence between MRI acquisitions and pathology, which allow for a closer picture of how different pathologies or neurodegenerative changes in the brain are reflected in MRI signal. Please, Laura.
Yes, thank you very much for your kind words, and I'd like to thank the organizers for inviting me to talk about this exciting work from MRI to microscope, translating pathology. Let's see how this works. Go back, yeah. Because what the main question generally is, what are these underlying changes and the underlying neuropathology? And I mean that in the broader sense. It can be the protein accumulation, but also the neuronal glial or other changes that occur in the brain that we see actually that are related to these neuroimaging changes, differences that we see in these various neurodegenerative diseases. So in essence, we need to build a bridge between the MRI and the microscope to the neuropathology. And my aim is to do this with post-mortem MRI and pathology. And I'll first go through the process of how we combine this, how actually the pipeline is working. We generally collaborate closely with the Netherlands Brain Bank, which has a very beautiful cohort of patients enrolling in their brain donation program. We also collaborate with our own anatomy department, which has the whole body donation program in which we have most of our control donors enrolling. And we have a dedicated team that is available 24/7 whenever a donor becomes available to get to the hospital within the hour and actually initiate this whole process. And for now, we are actually including control donors, Alzheimer's disease, Parkinson's disease, also including dementia with Lewy bodies, and more recently in the past 2 years, also frontotemporal dementia. Of all of these cases, we have the clinical information. For instance, with the Alzheimer's disease donors, we prioritize those that were seen at our hospital institute. So we have all the clinical information available on the demographics, disease duration, etc. Sometimes even antemortem information, whether it's PET, CSF, or other MRIs. So after they pass away, we get a phone call, and what we do is that we immediately head towards our University Medical Center and first perform an MRI, and that would be an in situ MRI. In situ meaning the brain is still in cranium. Only a few hours after death, we go to the radiology, perform the MRI, and all the MRI sequences are actually the same, very similar to the in vivo situation. Because what our aim is to translate back to the in vivo, the living situation, to be able to translate our insights. So we perform this in situ MRI, whether it's a T1, T2, diffusion, single shell, multi-shell, any of these sequences that can also be performed during life. And on a subset of cases, after the autopsy, we also perform 7 Tesla ex vivo MRI. So after the in situ MRI, the body is transported back to the mortuary where the craniotomy takes place, and there the neuropathologist is ready to perform the craniotomy and the dissection protocol. We dissect for frozen tissue, mostly for all sorts of molecular and biochemical analysis, and we dissect for formalin fixed and perfume embedding tissue for all sorts of immunohistochemistry related things. And most of the areas throughout the brain is being sampled, so many regions throughout the brain. Subsequently, a neuropathological diagnosis is made by the neuropathologist. So the neuropathologist on any of the neurohead to either match or to see if there's any co-pathology, etc., also present. So with this whole cohort, we have a neuroradiologist assessing the MRIs, neuropathologists assessing the neuropathology. So in essence, a very beautiful cohort to actually start our studies with. On the neuropathology part for our own studies, we generally tend to go towards the digital quantitative pathology, so also to use the quantification rather than just the staging of the disease. So to give you an idea from, okay, this is how our pipeline works, to first show an example of this in situ MRI. This is an Alzheimer's disease case with posterior cortical atrophy. On the left, you see a T1 image, and you actually see some atrophy indeed in the parietal regions. And on the right, you see a flare image with some hyperintensities there. But the message here is that it looks on first sight very similar to an in vivo MRI made during life, which is maybe a bit more atrophy. So that was also a question that we had in mind, like, okay, how comparable are these post-mortem MRIs? I can tell you that they're very comparable, almost similar to the in vivo situation, only a few hours later. But of course you would ask, well, just show us. And we did by a very special donor. It was a 37-year-old man. He came to the Alzheimer's Center. He was diagnosed with Alzheimer's disease about 4 years prior with a PSEM1 mutation. And in the Netherlands, we are in a fairly unique situation that euthanasia is legalized. So this patient who came to our center decided to perform the euthanasia, but he felt like he wanted to mean as much as possible towards towards the patients, towards the scientific community. He said, well, how can I help? He helped tremendously. Well, he underwent some more neuropsychological testing. He underwent an in vivo MRI, and 4 days later, he passed away. And he also enrolled as a donor within the Netherlands Brain Bank. So we were able to perform the post-mortem MRI as well, with subsequent anatomy and dissection. So we wrote a case report about this, and actually showing the ante and post-mortem changes or similarities with only 4 days in between. And this is actually what it shows like. And if you just have a look, you can have a look at the ventricles, at the white matter. You do see some changes because it's moving, but also in a way very similar. We did some analysis on this, for instance, with cortical thickness, measuring cortical thickness ante-mortem and post-mortem, and we saw a very strong correlation with these values. Also with some other measures, like diffusion measures. Sure, they changed a bit, but linearly they had a very good consensus ante-mortem, post-mortem. So this actually gave us some trust to proceed with the type of research that we're working on, that our post-mortem work can actually be translated back or can actually be meaningful towards an in vivo situation. So with that, we actually moved towards our main research question. What is the pathological sensitivity of these different MRI measures, whether it's the T1, T2, flare, diffusion measures, and the different neuropathologies, whether it's amyloid or tau, alpha-synuclein or TDP, but also a bit deeper, iron, myelin, synaptic densities, etc. How do these relate? How can we go towards a combined measure that explains some of these neuroimaging changes? And we tend to perform this within three main directions. The three main directions being the first one more into cortical changes, so what's happening throughout the cortex, cortical changes with accumulating of protein, or in MRI with atrophy measures or patterns. Also towards selective vulnerability of specific regions, for instance, the amygdala, the hippocampus, what's going on in there, how can we relate MRI and pathology in there, and lastly towards different projections or the network analysis. And with projections, I mean, say from the nucleus basale beinert or the substantia nigra projecting to either the cortex or to different regions, can we actually trace those projections and do the integrity of those be meaningful in measurement or related to underlying neuropathology? With a network measures, with integration or segregation of the brain, how does pathology contribute to that? I'll give a brief example of each of these. And we'll start with the cortex and with atrophy patterns in Alzheimer's disease. Atrophy, for instance, the cortical volume is often used as a secondary outcome measure in clinical studies, but also in trials of disease-modifying therapies. And therefore, it would be very beneficial to know which markers are actually driving or contributing to these changes in atrophy or in volume here. And one of the PhD students looked at this, and he looked at different cortical regions for which we had tissues sampled, and he saw different changes in atrophy. For this study, we included amnestic patients, so typical Alzheimer's disease, but also more non-amnestic patients. For instance, more with behavioral or with visual spatial problems, language dominant type of Alzheimer's disease, and also try to see if there were some changes in there. Well, we found several temporal, parietal, occipital changes in the atrophy patterns of Alzheimer's disease, with the posterior cingulate cortex being a little bit distinguished between more typical and atypical Alzheimer's. Within the different phenotypes, not that many differences were shown. However, more interesting, of course, is now the association with pathology. So that's what we did. And with amyloid beta was actually a first interesting result, because what we found was that an increase of amyloid was associated with an increase in volume, so more of some kind of swelling. So what we see is some global swelling. A previous study suggested maybe due to the space occupying process of amyloid beta. Others may had looked into the mediating factor of inflammation in there. However, this kind of information is quite important towards, for instance, the disease-modifying treatments, in which if you clear amyloid, you may actually observe a decrease in volume. That's also what some of these studies are showing, and what we here also show with actually the neuropathology in amyloid. Furthermore, for hyperphosphorylated tau, we didn't actually find much of an effect, although we did expect that based on the previous study in cortical thickness, in which we actually found an association with tau. So maybe the volume was not as sensitive, but maybe it was also to do with the phosphorylated tau maturation of our immunostaining, or even the combination of threads and tangles. For now, for this study, we combine them in an area percent of the tau burden. However, it's not known that threads and tangles have a differential contribution towards neurodegeneration. Leading towards neurodegeneration, we also had a marker of neuroaxonal change. So this is the neurofilament light marker, which is now more often used as CSF or blood-based biomarker in the clinic. We also looked at that and we saw a strong association with cortical volume loss. So neuroaxonal damage related to these to atrophy in Alzheimer's disease. To actually highlight this neurofilament light a little bit more, as it's also used, as I mentioned, in a clinical research setting. When we look at the neurofilaments a bit more in depth, because we have the pathology data, so we did some confocal imaging on that, and we saw the neurofilaments, they were swelling or glia cells surrounding them, and even in the last form, in number F, where you actually see transaction of the neurofilaments happening. And we did not just see this in Alzheimer's disease. There was actually a study in Parkinson's disease and Parkinson's disease dementia, where we actually observed this, especially in the dementia cases, in the middle temporal cortex. So it all seems to make sense within the neurofilaments as a global measure, also having very regional specificity. To come back to the atrophy patterns, we also looked at a subset of donors had antemortem MRI at various time points. So how comparable were they on a regional basis? Well, first, on a global basis, we saw that within 2 years, within a 2-year interval between the antemortem MRI and the postmortem MRI, about 100% of AD cases had less than 10% difference. However, there's large regional variability. For instance, within the hippocampus, we see that 80% of cases had less than 10% difference within 2 years, which seems nice. But between 2 and 5 years, this change was already, the variability was very high, up to around 250% difference. So using antemortem MRI with neuropathological validation, you have to be very careful with your postmortem interval, and therefore we prefer to use the postmortem imaging, especially towards these regional variabilities, where you also see that different regions are affected differentially at different stages in the disease. More will follow on that. So to wrap this cortical exploration up a little bit, I'd like to tell you a bit about some of the future perspectives. Because now we tend to use different regions which we sample throughout the brain, but we like to be ambitious, and next we're actually sampling throughout the whole brain. We have a PhD student working on Alzheimer's disease, and she's basically the whole brain is being imaged, like in situ, ex vivo, but then also sampled. So around 800 tissue sections are being stained for amyloid, for tau, for neuronal markers, and a few other additional markers in the future. And we can actually see, for instance, the asymmetry, which will become apparent in this case as well, but also then the relation towards neuroimaging on in a co-registered manner. So neuropathology directly co-registered with neuroimaging throughout the whole brain. We have several cases that we will process like this. I'm very excited about the upcoming results. So to move on to some more examples, you've already heard a lot about late neuropathologic change, and I'll continue on this a little bit in our post-mortem MRI, since there is no in vivo marker for late yet. Let's see if MRI can also contribute. So what we did, we had around 17 late donors, so donors with late pathology. We matched these age, gender, and neuropathological staging matched with a non-late donors. This was all within neurodegenerative disease, so they did have Alzheimer's or Parkinson's disease, but then with or without late co-pathology. In this cohort, first as a proof of principle, in this cohort we found significant shorter disease duration, which is expected within late. We found a higher CDR scores, a score for dementia, so more severe dementia in these cases, also made sense. Higher medial temporal atrophy scores on MRI, and also more hippocampal sclerosis. And these are all points that have also been shown in the literature. So what we did, we compared the hippocampus and the amygdala volumes in these late versus non-late cases within neurodegenerative disease. So first we combined the whole cohort, and in the whole combined cohort we saw indeed lower amygdala and lower hippocampal volume. What's important here is that we controlled for the primary pathology, so controlling for amyloid, tau, and alpha-synuclein. So hopefully focusing only on late, we saw actually lower volumes in our cohort. About 26% of the amygdala and 19% of the hippocampus. Now, stratifying in disease states, so first on the Alzheimer's disease, we found a lower amygdala volume and also lower hippocampal volume, again, while controlling for amyloid and tau. In the Lewy body disease cases, which consists of Parkinson's disease, dementia, and dementia with Lewy bodies, we predominantly found a lower amygdala volume. Again, controlling for the neuropathology of alpha-synuclein. So this is all very interesting data in which we see lower volumes of these specific regions. Of course, within a subset, especially of the Alzheimer's disease, which had available the in vivo MRI, we checked again. And here we didn't find as much an amygdala, although towards the trend, maybe due to our small sample size of late donors. And again, a hippocampal volume did difference. So as a general note on this, we do see that the hippocampus seems to be more affected rather than the amygdala, even though in the staging system you would expect first the amygdala, then the hippocampus. But we expect, as shown this morning during the talks, the TDP-43 interacts with co-pathology, especially with tau within the hippocampus, exacerbating the atrophy within that region. So as a take-home message on this study, that in AD and Lewy body disease, the amygdala and or hippocampus may be a good marker for possible late diagnosis, although further studies are necessary towards some kind of cutoff on the lower, which percentage may be indeed possible late. Towards some other future works that we're working on, especially towards the hippocampus, is to look at the hippocampus subfield, zooming in a bit more. This is quite some extensive work in which we look at different disease groups again, segment the hippocampus into different subnuclei on the histology, but also on MRI, for instance, with FreeSurf or other programs in which you can do a hippocampus subnuclei segmentation, and then look at the different atrophy patterns. Here's an example of, for instance, the distribution of tau within all these different disease groups, from controls towards Alzheimer's disease, but also a bit in Parkinson's disease and Parkinson's disease dementia. Very preliminary results. We don't really see any effects for amyloid, for tau mostly within the Parkinson's disease, similar for amyloid for alpha-synuclein, and within other important aspects, again, the clinical translation, and that we indeed see that the hippocampal subfield, especially towards the subsubiculum and the entorhinal cortex, shows a relationship with cognitive decline in vivo. Further up with these studies, we're also looking at synaptic density. So again, using the confocal microscope of these different subfields, looking at synaptic density, so there has synaptic atrophy in there as well. Very preliminary results show something occurring in the subiculum, entorhinal cortex. More information, more studies coming, especially again towards the subfield atrophy patterns. So lastly, I'd like to show you something about the integrity of different nuclei and their projections to the cortex. And we had a PhD student working on this. She'll defend her thesis by the end of the year, who looked at the nucleus basale minor and its projections, substantia nigra and its projections, the locus coeruleus and its projections, and especially the pathology within those regions. What effect do these have on the fusion outcome measures of microstructural integrity? Some example where you can already observe the cellular loss occurring in these regions. How do these influence maybe the regional microstructure as well as the projections? I'll give an example here on the nucleus basale minor as being the cholinergic system, and very important towards cognitive processing, towards cognition. And we did a clinical MRI and pathology study. At first, looking at clinical slash MRI, is that the dementia score, so a higher form of dementia, related to an MRI to a deterioration of the nucleus basale of Meynert and its projections towards especially the temporal cortex. So this can also be done in vivo. It's more of a validation. Do we indeed see a deterioration of the NBM and its tracks? Yes, we did. So then from clinical to pathology, which is also more of a validation, we did see that higher CDR scores, so more dementia, was correlated with a reduced chat cholinergic cell density within the NBM, also validating what's known before. But what our research can actually add is in between the MRI pathology, and that's what we did. And here we actually see an example in which a decrease in chat and cholinergic cell density is related to an increase in microstructure, meaning microstructural deterioration. In the blue box, you see a control case, so there's lots of cholinergic cells available, and you see a relatively low mean diffusivity. In turn, in the red box is an Alzheimer's disease case. You see a lack or very little cholinergic cells left, and a very high mean diffusivity, meaning there's a lot of space, there's a lot of microstructure being damaged in there. And what was interesting about the study, other than that we were able to pick this up within the NBM, but also towards its projections towards the temporal cortex, is that, well, this was specifically in a subgroup, so related only present in the amnestic donors, so some kind of stratifying method that this microstructure could have in the cholinergic system towards amnestic and non-amnestic AD donors. And of course towards translation towards patients. So to summarize, to come to an end, we can all go towards our coffee break, is that these cohorts with clinical, radiological, neuropathological data, they are a fantastic resource for various types of studies and also for brain banking initiatives. We can address the pathological sensitivity of different MRI outcome measures towards the contribution of different proteinopathies towards volumes or specific nuclei or projections, and also other markers of interest. This kind of knowledge is very important to address clinical questions and in the clinical research setting, for instance, towards the identification of neuroimaging biomarkers. There are some future perspectives on this. For one, on the MRI side, that we're very interested in other modalities rather than just atrophy or diffusion, but also T1, T2 ratio, look at iron or myelin or other markers related to that. Connectomics, see what the network is doing with the integration, segregation, and how neuropathology is associated with that. And also mention towards the underlying neuropathology or neuronal glial markers, to also include those a bit more and to actually get a better feeling of what's going on there within like a full model of neuropathology, glial and neuronal changes in there. So more is coming towards that. And also to get something from the in vivo and the ex vivo imaging, especially ex vivo, where you can pump up the resolution so much and get some additional information, and to translate that back towards to the in situ, towards the in vivo situation, which is a very nice collaboration with the Jesús lab at Penn. So also to get the best of all the different worlds. But also the inclusion of much more clinical information, like on a subset of these AD cases which are known at our center, we have a wealth of information. We hope to build something similar for the Parkinson's and DLB donors, but also for the controls. For the controls, it's especially difficult to get more standardized information. However, a multi-scale approach, I'm very excited about the possibility it has, and to, when you elucidate the neuropathological underpinnings, to better understand what you're actually using in neuroimaging, and to better understand the neuroimaging data sets in the clinical setting. So basically go from the clinic towards the neuropathology, or maybe even further. So with that, I would like to thank you so much for your attention. I'd like to thank the team back home who are doing most of this work, especially also the autopsy teams, as mentioned, 24/7 available to include donors. But last but not least, the brain donors and the next of kin to make this kind of research possible. With that, thank you very much for your attention.
Thank you very much, Laura. I'm afraid we can't go to coffee break quite yet, because we want to allow some time for a scientific discussion of these great presentations. And I'm sure there are lots of interesting questions in the audience. Please, I don't know if you have to remember everything you've been thinking of during this last 1 hour and a half. There's one.
No? Okay. Congratulations. A question for a clinician, Dave. All the proposal criteria for LATE are based on cognition, but taking in consideration the role of the insula, do you think that there could be any behavioral clue in these patients that you may be aware?
I think it's on. Oh, there it is. So you're asking about behavioral symptoms. And so for late, I think to some extent, I think as a way of sort of separating late from frontotemporal dementia, the behavioral phenotype of late has been a little bit underplayed. And I actually do think some of these patients have some degree of disinhibition is something I've seen in a number of them, as well as other kinds of theory of mind types of deficits that I think need to be more closely studied. Because again, if you look at the topography of where the pathology is, it includes insula, orbital frontal cortex, other areas of frontal cortex that, are clearly important for for memory, and also temporal poles, another area that's important for theory of mind of others. And so I think it's very likely, particularly in these more severe cases, and I've definitely gotten this sense clinically, that there is a behavioral phenotype. And we were talking earlier that in many ways, although in a different pattern, the pathology overlaps a lot with TDP type C, which is associated with the right temporal variant of FTD, which has a really sort of distinct behavioral phenotype as well. And so I think it's more about mining and better classifying these patients. And I think you need to do that in vivo in order to look at these things, which is why even with an imperfect criteria and without a molecular biomarker, it's kind of key for us to be able to start to analyze those individuals, at least people who are enriched in this underlying diagnosis.
Okay, that's
Thanks. Very, very nice session. I was gonna follow up on that question, but in the biomarkers perspective. If I remember correctly, in the new criteria, you said that tau positive participants could only be assessed as possible. I was thinking, have you considered at any point to consider the regionality of this tau pathology? Of course, with blood or CSF, you cannot look at that. But with tau pathology, if you see a pattern that is more cortical than limbic, could this make them move to the probable?
Yeah, so, I think at least based on what we, this is a sort of opinion-based consensus criteria, we felt, and we also wanted to make this something that could be operationalized in a clinic. We didn't get into as much nuance in terms of thinking about the amount of tau pathology or the location of tau pathology with regard to the atrophy. That being said, certainly when there is a fair bit of tau pathology, and it's not in the medial temporal lobe, that would, and yet there's a lot. I mean, I think in general, I should just say, if you have a lot of atrophy in your brain without a lot of evidence of tau pathology, I think we know based on postmortem studies that, Laura's doing, we're doing, that, it's unlikely that Alzheimer's is a primary driver of that pathology. You almost always see some other pathology there as well. And so to the extent that tau PET provides a quantitative measure of load of neurofibrillary tangles, I think it is reasonable to infer from what you see on tau PET relative to atrophy, whether or not Alzheimer's is, again, the primary driver versus whether it's likely late or some other underlying pathology.
I think, okay, there's another question over there.
Hello, okay. Thank you all for your presentations. I'd like to ask a question to Professor David as well. It seems to me, at least, that late and primary age-related tauopathy seem to share a lot of clinical and imagological, they have a lot of similarities. They are both milder forms of predominant amnestic cognitive impairment, and imagologically they both present with mesial temporal atrophy. And my question is if there is any clue, any imagological clue that you have to differentiate between both these entities.
Yeah, I mean, I think part is a challenge from a clinical perspective, in that I think, you know, for the most part, sorry, those individuals have relatively lower tau loads and don't have as much atrophy. I mean, we usually don't see the kind of severe atrophy we tend to see with late. And, you know, again, at least and some of this is my speculation more than clear data for this, my intuition is that in part, you know, that our tau PET measures at least are sensitive to tau load, not necessarily tau stage. I think someone earlier showed a nice dissociation between stage and load. Brock stage is not a great measure of how much actual tau is within, you know, the medial temporal lobe, and you can see huge variation in tau. Sometimes a Brock stage, you know, 1, 2 has much more tau than a Brock stage 3, 4 within, you know, early tau regions. And so my instinct is that tau PET may be sensitive to those cases where PART is a primary driver, where you have enough tau load that you would expect to see some degree of atrophy. But I definitely think, you know, PART is in sort of the differential for late and is a confound. And then there is some data out there that some of the more symptomatic PART cases have TDP associated with it. And so there may also be this sort of synergy that occurs with them, you know, as well. But there's a lot of overlap, both symptomatically and in terms of regionally. Because, you know, if you look at Brock stages, it also tends to be more anterior and also moves into orbital frontal cortex. And so they both, to some extent, at least the tangle part of you know, AD, follow this anterior medial temporal network that is interesting to see in terms of how you think about spread and connectivity within those two conditions.
We have another question over there.
Thank you for your presentations. In this sequence about late and PART, from what I am learning, both of them maybe can be found in postmortem brains, tauopathy and late neuropathological change in cognitively healthy individuals, and the same we know can be found in Alzheimer's disease patients. So how can we and I think this is crucial for clinical trials, how can we, in the face of for clinical trials and for treatments in pre-symptomatic patients, how will we be able to detect which patients that have these neuropathological changes, which of them will develop in the clinical? I wonder if any of you know that.
Yeah, I mean, I think that's, in some ways, with all preclinical disease, the million-dollar question is how to best predict who's more or less likely to develop symptomatic disease, and that gets into concepts that were talked about earlier today in terms of reserve and resilience. I mean, we have a number of patients in our cohort that have a late-like atrophy pattern of the medial temporal lobe who are cognitively normal, and you know, the question is, will they eventually start to develop memory symptoms? If we look in large populations, actually even amongst amyloid negative individuals who, you know, some of them have late, if you look at hippocampal atrophy, it is predictive of future cognitive decline. So in a probabilistic way, you'll know that those who show more of a, you know, late-like pattern, medial temporal atrophy, are the ones that are more likely to develop symptoms. But to do that at an individual patient level, you know, we're not there yet. And then it's the same thing with preclinical Alzheimer's disease. You know, if treatment is associated with toxicity, expense, you know, geez, you'd like to know if you're 75 years old and have preclinical Alzheimer's disease, are you going to develop symptoms in the next 3 years versus the next, you know, oh, I won't develop them till I'm 90. centurions, to be excluded. Most of us actuarially aren't going to make it much past 90, and so those kinds of questions I think are essential for our field. And again, it requires really good in vivo biomarkers to detect these things, so we can then start to better learn, what are some of the predictive models for who becomes symptomatic. I think that was answering your question.
Yeah, I have a question for Laura. And so I was really amazed by these images you showed of the whole brain stainings. And I wonder, and you also, so it was a single case, and you also mentioned that you had more cases processed this way. But I wonder, like from a technical point of view, how this information could be used like quantitatively, and whether you have these, because you showed it as like an image. I wonder if you have these as an 3D volume similar to a NIFTY file or to a neuroimage, to an MRI scan, which you could then normalize to some common anatomic space to analyze across different individuals.
Yes, absolutely, and that's exactly the plan. So therefore, we collaborate with the University of Amsterdam, other university, and they have this amazing technical expertise. Like they co-register all the 700 or 800 slides basically back together to make it one brain again, and register that to the neuroimaging. First, of course, to the ex vivo, so you actually have a 3D rendering at the same time of neuroimaging and neuropathology together. Yes, and there, within that, you can do the regional analysis, because you can apply segmentation techniques to both the histopathology and to the ex vivo imaging. And of 1 or 2 donors, we also have the in situ imaging plus in vivo, basically making that whole translational step.
Yeah, I think these kinds of techniques will like open a whole new door for world of opportunities for analyzing this data, because for now, the existing neuropathologic data has a severe regional sampling problem, right? And so we know the Prague stages, and the images look nice, but they are cartoons. Someone has painted them, and probably by looking at 5 different brain regions. And for TDP-43, we don't really know how much there is in the insula. Someone looked at some point at the insula, someone else at the orbitofrontal, but the whole distribution is like not well understood. And I think that's extremely important also for our interpretation of our neuroimaging data, because there we are used to looking at the very detailed spatial atrophy patterns that we say, yeah, it more or less corresponds to the spatial distribution of the pathology, but we don't really know the spatial distribution of the pathology.
Exactly, that's the whole point, yeah. And all the data will also become publicly available. So for a control donor, that has already been published. So all the data, like all the sections, etc., it's all available. For this one, is currently under review, so then also become available with links to download freely. Yeah.
Okay. So I don't know if there are any additional questions to anyone. If not, we can finally go to the coffee break. Big up.
Minute coffee break. We'll be back here at 5 p.m. Please pick your refreshment and get around that poster presentation that's been piquing your interest for the last few hours. We'll see you at 5 in here. Thank you. And welcome back. I hope you have some extra glucose circulating in your peripheral.